Welcome to part one of the objective examination of the lumbar spine. In this particular video, we'll describe the tests and measures associated with evaluating patients with lumbar spine disorders. I would like to thank my colleague at the University of Buffalo, Dr. Mike Brown, for his assistance with this presentation. The objectives for this particular presentation will be to describe the different tests and measures used to evaluate a patient with a lumbar spine disorder, evaluate data from the objective examination in conjunction with that of the subjective examination to assist in making clinical judgments to establish a diagnosis or differential diagnosis for individuals with a lumbar spine disorder, and demonstrate sound problem solving and critical thinking skills to independently examine and re-examine an individual with a lumbar spine disorder. In this particular presentation, we'll discuss observation, active range of motion, repeated movements, passive range of motion, muscle performance testing, neurologic testing, special tests, and then palpation. In part two of our objective examination, we'll discuss tests related to the sacroiliac joint. One of the first components of our physical exam will be observation. We're going to observe gait, and we'll look at posture and sitting and standing. Again, when we think about our treatment-based classification scheme, there may be some clues from gait and posture and sitting and standing that may give us some information with respect to a directional preference. For example, during gait, we may want to know, are there symptoms better, worse, or the same? And one example where they may potentially get worse is with lumbar stenosis. We know that with lumbar stenosis, extension forces narrow the central canal and can potentially cause symptoms associated with lumbar stenosis, and we see that on the top image with the individual on the right. When we see folks who are standing upright in extension and walking in that posture, they're going to get more symptoms down the leg. If you look at the image on the top again, but now in the individual on the left, they're walking with a shopping cart. And so we call it the shopping cart sign, where they're flexed forward a little bit. Well, that flexion forward opens the canal to some extent and takes some of the pressure off some of those neural structures. And so patients are going to feel better with a flexed gait. That would be just the opposite with somebody who has potentially an acute disc herniation. With an acute disc herniation, someone may feel much better with an extended posture, and they may feel worse with a flexed posture during gait. If we look at posture and standing, we'll want to determine, do we see a shift at all in the frontal plane? That could be related to an acute deformity, and we'll talk about that in a second on the next slide, and also look for scoliosis as well. We're looking for, once again, a curve in the spine and the frontal plane. We know that in the sagittal plane, when we look at the sagittal plane with respect to the spine, we look at the spine from the side, we know that we should see a nice lumbar lordosis. However, with respect to a static standing posture, when individuals who once again have lumbar stenosis, as is the image on the bottom left, we see the individual on the right standing in more of a flexed posture. That's going to take a little bit of pressure off those nervous structures, again, by opening the canal, less symptoms down the leg. If that individual is standing now with an extended posture, that's going to put more pressure on those structures and lead to increased symptoms down the leg. With respect to sitting posture, I would recommend just going ahead and just rating it as poor, fair, or good. And if we look at the graphic on the bottom right, we see 4 different sitting postures there. The 4 red marks, or 3 red marks next to the sitting posture, would suggest that those sitting postures are not optimal, primarily because the lumbar spine is no longer in a normal lordotic position. And that sitting posture in the bottom right-hand corner, where you see the green circle, that's likely the best out of all 4 of those, where we see the lumbar lordosis with respect to sitting. And so, again, take a look at gait and take a look at posture and standing and sitting. It could give you some good information. Just again to mention those sitting postures down there, it would be also important to correlate the symptoms associated with those postures. If we're dealing with individuals who have an acute herniated disc, they may not tolerate those flexed postures very well where their lordosis is no longer maintained. However, if you give them a chair or maybe a small pillow to put back there where we now increase the lordosis, that may take symptoms away. And so again, that gives us clues as to a directional preference for these individuals. In patients with acute low back pain, you sometimes may see the presence of a lateral shift. Again, we name these shifts by the relationship of the shoulders to the pelvis. In this particular case, this is a right lateral shift. The shoulders are shifted to the right in relation to the pelvis. And why do we see this? The number one reason we see this is likely due to somebody who has, in this particular case, left-sided radicular symptoms. However, when they shift away from that, it takes the pressure off those neural structures, and it decreases the amount of pain down the left lower extremity. The thought is, and it sometimes could be due to a large herniated disc, and they're moving away from that side to take pressure off those neural structures again. This is something that we will talk more about in the course, and this is usually something that we want to correct sooner rather than later. This acute deformity is not something we want to see persist for long periods of time. Again, this is an acute deformity. This is much different than a structural scoliosis where we see that S-shaped curve in the frontal plane. It's been there a long time. This is an acute deformity, and the patient will also often mention that I've shifted my shoulders, I feel like I'm shifted, but I'm shifted now because of the pain. In this case, it's likely left-sided low back pain and left-sided radicular symptoms, and the patient is moving away from that, again, to take pressure off those neural structures. So we've already had you review how to assess range of motion with the double inclinometer technique for the lumbar spine. There are other ways of doing that. You can use tape measures and standard goniometers, but for the most part, I think that using those double inclinometers is probably the best way to assess lumbar range of motion, except for rotation, which we'll use a standard goniometer for. But as you're evaluating range of motion, I think there's a couple of things you should be on the lookout for. And most of these occur in the sagittal plane with flexion. First off, we may see individuals who have a derangement that as they flex, they may deviate from the painful side. And so once again, they're moving away from that painful side. Individuals who may have adherent nerve roots may deviate to the side of the adherent nerve root in an effort to, again, avoid that stretch over that adhered nerve. Folks who have lumbar spinal stenosis may have marked limitations in extension, and we're going to start them. They may actually start in a little bit of flexion, but they're very, very limited with respect to extension because that's a posture they've avoided for long periods of time, because as they extend, they close down the canal and they make their symptoms worse. If an individual has a spondylolisthesis, where one vertebrae is slipped relative to another, we may see aberrant motions during movement, and they're usually better toward the end range. And these aberrant trunk motions, we spoke about them a little bit when we discussed the spinal stabilization clinical prediction rules, but really they relate to a couple of very specific findings. First off is an instability or a catch during range of motion, which means that as they flex forward, they may actually stop a little bit, they may get that catching sensation, and they have to maneuver past that. Or they may actually have a little bit of a giving way, that instability that they feel with that. You may see painful arcs, especially in the sagittal plane, where they begin to flex forward and there's no symptoms, and maybe about halfway in, they now report that there's symptoms, and then again at the end of the range, the symptoms go away. Thigh climbing, that's when the patient flexes forward, and to come back up from that fully flexed posture, they have to place their hands on their thigh and help themselves up to get back up into that erect standing posture. And then reversal of the lumbopelvic rhythm. Again, this is somebody who may flex forward, but then to get back up, they may actually anteriorly tilt their pelvis and hinge at the hip to return back up to that erect standing posture. And so I'd keep an eye on those, and those are good clues to have if we begin to see deviations with respect to range of motion can clue us in again to a specific diagnosis. The normal values, this is according to the American Academy of Orthopedic Surgeons. These are the numbers that we will use for the course. So flexion, 60 degrees, extension, 25 degrees, side bending or lateral flexion, 25 degrees, and then rotation will be 45 degrees. And so when we report numbers with respect to quizzes or case reports or examinations, these are the numbers that I would like you to go by. We'll report numbers according to the AAOS, and you can use the numbers that we give you to determine if they are either increased or decreased with respect to mobility. Take a moment and review the video on this slide that talks about the evaluation of lumbar range of motion, period. Watch the video up until 6 minutes and 10 seconds, and that will also include assessment of range of motion with a double inclinometer technique. Take a moment and review this brief video on the evaluation of lumbar range of motion with a standard goniometer. We've talked about the concept of active range of motion with overpressure several times throughout the course. The lumbar spine is no different, and we're going to overpress movements of the lumbar spine when they are not painful actively. Again, if you have movement and you have pain with movement, we're going to avoid overpressing. There really is no need to overpress in that particular case. We're going to overpress to clear the lumbar spine or to potentially clear a particular movement. On the next video, we'll show you one way of overpressing the lumbar spine for the different movements. Take a moment and review this brief video. It shows some of the hand placements and how to apply appropriate force when using overpressure to the lumbar spine. I think it's important to note again that we're doing overpressure to clear the lumbar spine or clear a particular movement that has not produced pain actively. Also, when you think about with respect to someone who may have primary hip pathology, we're going to screen the lumbar spine. Those movements may be pain-free, but to truly clear the lumbar spine, we're going to want to make sure that we overpress these movements, get them to end range, provide appropriate overpressure, and ensure that there's no symptoms associated with that. When we described the treatment-based classification scheme, we mentioned that one of the first components of our examination is going to be to evaluate range of motion, specifically repeated movements, to see if that patient is going to respond to a specific exercise program, meaning that we've either found a directional preference or a centralizing maneuver that we can utilize with our treatment plan. If that is the case, we're going to go in that direction. And so with respect to repeated movements, we're going to look at repeated flexion and standing, repeated extension and standing, repeated flexion and lying, and repeated extension and lying. And if there's a need, potential side gliding and standing as well. But the movements in the sagittal plane are the ones that we'll likely utilize the most with our initial evaluation with our patients with lumbar spine disorders. Although we spoke about the treatment-based classification scheme and this category of specific exercise for folks who have a directional preference or those who centralize, it's important to refer back to the McKenzie group and the MDT classifications. And so take a moment and review these. I know you've discussed them in the past with Dr. Schenk as well as Dr. Case, but go ahead and review the definitions for derangement syndrome, dysfunction syndrome, and postural syndrome, because they still will play a role with our patients with lumbar spine disorders, especially if they fit in those categories that deal with directional preference and centralization. It's important to review the responses to movement that could occur as we repeat movements during our lumbar spine examination, especially those with respect to flexion and extension. And really what we're looking for during the movement are these descriptors that the symptoms have either decreased or potentially abolished or potentially have centralized. And then hopefully after, we see an individual who says that my symptoms are now better and they have in fact centralized. And so those are movements that we're going to want to capitalize on with respect to our exercise prescription. So if we see those descriptors of either decrease, abolish, or centralize during the movement, then after the movement they're better and they in fact have centralized, we're going to want to capitalize on those particular movements, and that's really going to play into our exercise prescription for the patient if they fit in that specific exercise category from our treatment-based classification scheme. It is important to note that as we move patients through this repeated movement scheme, that we may potentially get individuals who tell us that they're worse or they've peripheralized, or as we move them through maybe a couple sets of 10, 15, 20 repetitions, that they are no better or no worse, or we've had no effect at all. And so this traffic light guide, you've talked about this before with Dr. Case, but I think it's important to reiterate it now. Really what we're looking for are these individuals who are better, where the symptoms have abolished or they've centralized, right? And those are the individuals that, again, we're going to want to capitalize on, prescribe those movements, and ensure they're doing them several times through the course of the day to hopefully mitigate their symptoms. If they're no better, no worse, no effect, we're going to reevaluate that. We're going to come back to that at some point, reevaluate that. There's also a chance that patient may fit in another category. If we're dealing with symptoms that are radicular in nature, is there a chance that this patient could potentially fit the traction classification component? Perhaps. Maybe they have a cross straight leg raise, or even worse, maybe they peripheralize with extension type movements. Then we're going to want to get that patient into that traction category. But nonetheless, we're going to continue to reevaluate repeated movements through the course of our exam or through the course of care. And if a patient ends up fitting at in that category at some point in time, we want to make sure that we capitalize on those movements, because even if we put a patient in a manipulation group or we put them in a traction group and we think that extension movements would be beneficial for them, we're going to continue to evaluate that. And at the end of the day, they may get to a point where they're better with those particular movements. And so just because we don't get it on day one doesn't mean we can't go back to it down the road. But again, I think as you're evaluating patients, if you're finding movements that are worse or they potentially peripheralize, there's really no need to continue with those. We're looking for better abolishment and centralization of symptoms. And remember, when we think about the specific exercise group, how are we going to progress those folks down the road? First, we can start with self-generated joint active range of motion. Then we can move along to self-generated joint active range of motion with overpressure. Then we can move into clinician overpressure, followed by clinician mobilization and clinician manipulation. And so if the patient's fitting that specific exercise category and we're going to prescribe exercises for them, we want to make sure that we exhaust this progression of forces, because that's going to be key, again, to hopefully achieving a successful outcome. You've also spoken about passive range of motion at different body areas in the course. Passive range of motion also applies to the lumbar spine as well. And passive range of motion in lumbar spine is sometimes called passive physiologic intervertebral movements. You may hear that abbreviated as PIVMs or PPIVMs. And if you hear that term, we're dealing specifically with passive range of motion in the lumbar spine. And so why would we do passive range of motion in the lumbar spine? Well, one reason might be that when we watch patients move, we may see movements that are a bit aberrant. We've already spoke about those. We may also see deviations with respect to movement. And we may speculate that perhaps a segment or two may be either hyper or hypomobile in comparison to the neighboring segments. And that can inform our interventions. If a segment is hypomobile, right, we're going to use manual therapy likely to address that particular concern. If a segment is hypermobile, it may help us with respect to our strengthening or our motor control exercise prescription. And so when we do these passive physiologic intervertebral movements of the lumbar spine, they're going to be done in side lying. Typically, we're going to look to reproduce the patient's symptoms, and we're really going to assess movement between different segments of the lumbar spine. We can assess end feel. With respect to flexion, we should note a firm end feel, extension potentially firm or hard if we have approximation of the bony segments, and then side bending and rotation could be firm or hard depending upon if we're dealing with compression and approximation of the zygoapophyseal joints. We're going to grade passive range of motion as being hypo, hyper, or normal. And again, we're going to use these grades based upon the findings that we see above and below with respect to segments of the lumbar spine. One of the handouts we'll have posted for you will be OMPT exam and treatment of the lumbar spine. And this is a handout that was put together by the folks at the Army Baylor program that outlines some of the examination and treatment techniques that we can use from an orthopedic manual physical therapy perspective. This is the page that describes the PIVMs for the lumbar spine. We're also going to show you a video on the next slide. The one thing I want to point out is that you can use these PIVMs we mentioned about examination purposes to determine if a segment is hypo or hypermobile, to determine end feel. We can also use it for intervention, and so these are for patients who potentially are maybe severe or irritable, and we just want to begin to get some mobility moving through the spine, and so these techniques can be used for that as well. I will also mention that part of the technique used for flexion as well as the techniques used for rotation will be used for the setups for our thrust manipulation that we'll teach in the fall to localize our forces at a particular segment. So these handling techniques are important for really a variety of different reasons. And so we'll let you review the video on the next slide. The one thing I will mention though is that the PIVMs can be done different ways. The way that the examiners on the video do flexion, extension, lateral flexion would be very consistent with how we would teach it to all of you. Rotation can vary though, and they look at rotation through the pelvis. We sometimes teach rotation through the trunk, a little bit more proximal, and so that's one deviation that you'll see. But once again, take a look at the video and get an understanding for how to perform these PIVMs. Take a moment to review this video, which shows you passive physiologic intervertebral movements, or PIVMs, for the lumbar spine. We've discussed the concept of accessory motion and joint play assessment and other body regions as well. With respect to the lumbar spine, we are going to talk here about passive accessory motion testing or joint play assessment. This is sometimes called PAVMs, or passive accessory intervertebral movements, and like I said, you'll hear that called PAVMs sometimes in the clinic. These are performed in prone, very similar to what we've done for the cervical and thoracic spine, and we're looking to really do a couple different things here. Number one, we're really looking to see if we can produce the patient's concordant sign. Can we reproduce the patient's primary symptom complaint with our passive accessory intervertebral movement assessment? We can also assess motion at a specific segment, and we can grade that motion at a specific segment. We can either grade that as being hypo, hyper, or normal, and depending upon whether or not we're checking either it's central over the spinous process or more unilateral over the transverse process, we're going to compare to the joints above and below. And we can also, if we're doing a unilateral assessment over the transverse process, we can look at bilateral comparison. And we can also assess end feel. And the end feel for all these movements should be firm. If we begin to note an empty end feel or something other than firm, that might be a bit of a concern. So again, when we do our passive accessory motion testing, we're going in, we're evaluating to try and reproduce the patient's primary symptom complaint, and we're looking to determine whether or not there's mobility associated with these segments. We can grade that out as being hypo, hyper, or normal. When we talked about the manipulation clinical prediction rule, this was how joint hypomobility was graded through passive accessory motion testing. And it's also important to note that when we think about treatment for individuals who fit that manipulation clinical prediction rule. If we're not going to use thrust, which we're not going to teach you that this particular semester, we will in the fall, but if you're not going to use thrust, you can use central or unilateral vertebral pressures as a treatment as well over those segments that you identify as being potentially hypomobile. I mentioned previously that we'll have a handout for you titled OMPT Exam and Treatment of the Lumbar Spine. That'll be located in the Blackboard site, and it provides photographs for you of the different assessment techniques as well as treatment techniques as well. And this is what that particular handout looks like for our assessment of passive accessory intervertebral movements, or PAVMs. And you can see in the top image there, the examiner is doing a central posterior to anterior pressure using that same horse and jockey technique that we've talked about before with respect to hand placement for the lumbar spine, or for the thoracic spine rather. And then we're looking at a unilateral posterior to anterior pressure on the picture next to that. And then the photograph down at the bottom looking at a transverse pressure as well. And we've done these exact techniques for the thoracic spine, so this should really be nothing new at this particular point. But again, as an examination, we're looking to assess segmental mobility between vertebral segments. We're also looking to potentially provoke pain and determine if that pain is consistent with the patient's primary symptom complaint. We can certainly use this to treat, again, primarily to increase range of motion and mobility. We can use it to reduce pain if we use grades that are a little bit lower, and it can also be used to assist with reducing muscle guarding and spasm if we use those grades 1 and 2. Grade 3s and 4s would be used to improve mobility, and these movements primarily will likely improve extension, at least the centrals will, and the unilaterals can improve active extension, side bending, and rotation as well. So take a moment and review this video, which shows you passive accessory motion testing or joint play assessment of the lumbar spine. Again, very similar to what we did for the thoracic spine. Pay particular attention to the hand placement, and how your hand should be positioned for you doing central techniques as well. Muscle performance assessment is extremely important for individuals with lumbar spine disorders. I think this is one of the areas that we can always improve upon, and we can always help patients get better quicker by knowing how to accurately assess and then intervene in terms of muscle performance. And so we'll talk about a couple different areas of muscle performance. First, we'll talk about manual muscle testing, and manual muscle testing will be for trunk flexion, extension, and then trunk flexion with a rotational variant. We'll speak to resisted isometric and muscle endurance testing, and we'll talk about specifically what we call the core endurance tests of McGill. We'll also discuss a front plank test that you can use with your patients. And then, as part of the treatment-based classification scheme, we did talk about a particular group of patients who would fit primarily into the spinal stabilization group, and that's based upon a clinical prediction rule developed by a physical therapist named Gregory Hicks. And so we'll take time and we'll review that as well again. This video will describe manual muscle testing for trunk flexion. This video will describe manual muscle testing for trunk extension. This video will describe manual muscle testing for trunk flexion with a rotational variant. In addition to manual muscle testing, we can also assess resisted isometric and muscle endurance performance as well. And these tests are nice because it assesses performance beyond that one repetition that we sometimes see for manual muscle testing. And in some cases, these type of tests here are a little bit more indicative of performance of the trunk musculature. And so For these particular activities here, we call these the core endurance tests of McGill. We're dealing with a flexor endurance test, a left and right side plank, as well as an extensor endurance test. And for each of these, we show a video on the next slide that gives you a good understanding of how to test for each of these. But I think it's important to know who are these tests designed for. These are designed for individuals who likely have low severity, low irritability. So for your patient with acute low back pain, these are not the tests you're going to do on day one. I think these are tests that are done as the patient progresses through the course of rehabilitation and you're looking to become a little bit more aggressive with your interventions with respect to muscle performance. So take a moment to review these core endurance tests of McGill on this video, on this particular slide. I would also watch all the way to the end, because at the end they describe how to interpret the scores of the test, which is very helpful. And so let's go ahead and talk about the test that you just saw in the last video and the scoring rubric that they used. Here's some data actually from a study that was published on college level intramural athletes with and without low back pain. They used the Michelli Functional Scale as their measure of disability, and the individuals with low back pain had moderate levels of disability in this particular study. And so if we look at the athletes without low back pain, look at some of their data. If we look at the ratio of trunk flexors to trunk extensors, that appears to be in order. The performance of trunk extensors should exceed that of trunk flexors. And then if we go down and we look at the ratio of the right and left lateral plank performance, we see there's some asymmetry there. We would like to see those the scores for the left lateral plank in those athletes without low back pain. We'd like to see that increased a bit. And then if we look at the ratio of the right and left lateral plank to trunk extensors, those seem in order as well. Should be no more than 0.75. If we go over to the athletes with low back pain, there's a couple of interesting findings here. First off, the trunk flexors performed better than the trunk extensors, and we should not see that. That number should not be, that ratio of flexors to extensors should not exceed 1, and it does in this particular case. If we look at the ratio of right to left lateral plank performance, we see asymmetry there again. We'd like to see those left lateral plank scores improve a little bit. And then if we look at the ratio of the lateral plank scores in relation to trunk extensor scores, we see a concern there as well, because the trunk extensors are not performing to the level that they should be, especially with relation to the right lateral plank scores. And so in this particular case, with respect to the athletes without low back pain, if we're looking at those data, we would want to definitely improve that left lateral plank performance. If we move over to the athletes with low back pain, we're definitely going to want to improve trunk extensor performance in that particular group, and we're also going to want to improve the left lateral plank performance as well, so that those numbers with respect to right and left on the lateral plank, there's less asymmetry there. You're going to see a lot with respect to patients with low back pain. The trunk extensor performance can always likely be improved. Those are some of the muscles that we see affected most in these individuals. So we've talked about manual muscle testing, and we've also talked about isometric endurance testing as well, and how some of those numbers can help us with respect to our interventions and goal setting for patients. The other group of patients that I think always is going to benefit from a stabilization program are the individuals who met the clinical prediction rule on lumbar stabilization. This is the group that we talked about, one of the 4 we talked about with our treatment-based classification scheme in the lecture that we did previously. And so individuals who are going to be younger than 40, who have better general flexibility, in this case a straight leg raise of greater than 91 degrees. They may have an instability catch or aberrant movements during flexion extension range of motion, and then positive findings in the prone instability test, which we described as well previously. Those are individuals who are going to benefit from a stabilization program. We discussed the likelihood of success with this stabilization program previously, but just to review, if you stabilize all of your patients with that particular stabilization program, you'd get a success rate of about 33%, meaning that about 33% of the patients would have a 50% drop in their Oswestry score. That's what we call a successful outcome. If, however, we have 3 of the 4 variables on the last slide, the likelihood of success goes up to 67%. And so you can essentially double your success rate by just figuring out if those patients meet that particular rule, and then use the exercise program that we had described previously. Other important predictors of a successful outcome in that particular study that didn't necessarily make the regression model or the clinical prediction rule are histories of episodic low back pain, meaning frequent episodes of low back pain that sometimes seem to calm down on their own, but it's frequent episodes of low back pain with minimal trauma and minimal trigger associated with it. Higher scores on the FABQ, that's kind of interesting because when we looked at manipulation, we were looking at lower scores on the FABQ. With respect to stabilization, though, there's an interesting aspect with this particular exercise component because it's goal-driven, and sometimes patients who have higher fear do really well with that. Individuals who have higher pain rating scores, again, do well with the stabilization program. And then if we note hypermobility with our accessory or joint plate testing, those PAVMs, if we note hypermobility with that, which makes sense again as well, because we're not dealing with hypomobility. Hypomobility would lean more toward the individuals with manual therapy. This group here where we see hypermobility with their testing, those are folks that are likely going to benefit from a stabilization program. We've spoken several times so far about a stabilization exercise program, and this slide provides the exercises for you that are included in each of those studies. And so in the upper left-hand corner, in a supine hook-lying position, the patient there is activating their transverse abdominis musculature. So it's an abdominal activation exercise, and then that activation of transverse abdominis through that drawing in maneuver at the abdomen is then part of all of the exercises that we see here. So in the middle of the screen, you see a bridge. On the right-hand side, on the top, you see a partial squat. On the bottom, you see a lateral side bridge. And then over on the bottom left, you see alternating arm and leg. And so each of these exercises are going to focus on activation of the transverse abdominis, and then we're going to carry out each of these exercises. The next slide shows the progression for each of these, as well as the prescription for sets and repetitions. And again, this exercise program here is what I would recommend for all of your patients after we do some type of manual therapy with them, or if they meet that clinical prediction for spinal stabilization. This is the core group of exercises that I would recommend. I don't think that there's any reason you can't move off of these exercises, but this is the core group. If you want to prescribe more, that's perfectly fine, but at a minimum, you need to make sure that patients are performing these exercises correctly and progressing through these exercises. You can certainly add more, but this is the core group that we're going to recommend for our patients. And take a moment and review this particular slide here, because this slide provides the progression for each of those exercises. And so, for example, we talked about activation of transverse abdominis, this abdominal bracing or abdominal hollowing exercise. Once the patient can do that, right, we're then going to use bracing with heel slides. We're then going to use bracing with heel lifts, bracing with bridging, bracing with standing row exercise, and walking. And so we also can see the criteria for progression there. So it's quite clear, right, how many repetitions these individuals would have to perform with respect to holding that particular posture in a correct fashion before we can progress them. So this progression here, I would recommend from a clinical perspective, all of your patients with respect to lumbar spine pain, if you're going to prescribe a stabilization program, this is really what it should look like at its core. Can you deviate from that? Of course, but this is what it should look like from the core. The neurologic examination is going to be particularly important for patients with lumbar spine disorders because of the potential for nerve tissue to be involved. And so when we begin to think about who would we do a neurologic examination for, Any individual who has any symptoms into the lower extremity, especially down below the knee, if we hear about vague pattern or behavior of symptoms in terms of potentially multiple dermatomes being affected, the entire limb being affected, or potentially red flag findings, all of these would be indicated. If there are positive neurologic findings and there are concerns for red flag findings, it really elevates the need for diagnostic imaging if the nervous system's involved. And so we'll make sure that we discuss briefly myotomes, dermatomes, stretch reflexes, and we'll talk about central nervous system involvement as well. So Clonus, Babinski, and Hoffman will be important as well. And then lower limb neural tension testing in terms of the straight leg raise and the slump test. We'll be sure to review those as well. This slide provides the nerve root and the corresponding region for dermatomal testing. Make sure you take the time to review dermatomal testing, because once again, this is going to be important in our differential diagnosis. Again, when we deal with individuals who have lumbar spine disorders and one dermatome is involved, that's consistent with sometimes nerve root pathology. However, our concern is when we begin to see multiple dermatomes involved on the same patient and why that may potentially be. It's also going to be important to do a thorough myotomal assessment. And this particular slide shows you the nerve root with the action that we would want to assess. And so take a moment and review that on this particular slide so you feel comfortable assessing these different myotomes. The two muscle stretch reflexes or deep tendon reflex we'll be most concerned about with respect to the lumbar spine are the patellar tendon reflex and the Achilles tendon reflex. The patellar tendon reflex is associated with the L3-4 nerve roots, and the S1 nerve root is associated with the Achilles tendon reflex. Remember that when we're dealing with reflexes, we're looking to grade them as being hyper, hypo, or normal, and we're always going to use bilateral comparison with that as well. With respect to lower limb neurodynamics, we'll talk about the straight leg raise test as well as the slump test. And I would also refer you back to those Rob Roy Martin papers that were written on the hip, because he does a nice job discussing the influence of lower limb neurodynamics with individuals with hip disorders. As you recall, though, in his papers, he also wrote about the influence of the lumbar spine in individuals with primary hip disorders. And so we would have to consider lower limb neurodynamics as well for those individuals. And so in this particular case here, again, the slump and the straight leg raise test, we're really looking at the mechanical and physiologic properties of nervous tissues and those related structures. And primarily, when we evaluate patients with the straight leg raise and the slump, we're looking for reproduction of the patient's symptoms and potentially impaired mobility of these structures. And so when we think about what would make a test positive, number one, if we're reproducing the patient's primary symptom complaint or their comparable sign, if there are asymmetrical findings between the extremities, and if sensitizing movements change the patient's symptoms, meaning that do we see changes in symptoms with biasing the ankle with respect to a specific nerve, or changing the tension on structures with respect to cervical spine movements. And so if sensitizing movements change the patient's symptoms, we're also going to consider that positive. The straight leg raise test is one test that we're going to commonly use to assess lower limb neurodynamics and neural tension. And with this particular test, the individual is going to be lying supine with the head and neck in a neutral position. The examiner is going to support the leg at the heel and raise the leg to the point of symptom reproductions while keeping the knee straight. And we're also going to likely add in sensitizing maneuvers, and we'll talk more about that. But with respect to these particular images here on top, you can see the straight leg raise being performed with the knee in full extension. And then the bottom there, looks like there's some sensitization occurring with respect to ankle dorsiflexion and potentially hip adduction. Again, a positive test would be reproduction of the patient's primary symptom or concordant sign. If a sensitizing maneuver increases the patient's symptoms, and if there's asymmetries compared to the contralateral extremity. I would always recommend doing this on the leg that is not involved, and if there's consideration of bilateral lower extremity symptoms, I would likely start with the leg that is less involved or less painful. It's likely going to be a little bit easier to do on that particular side if there's not involvement of neural tissue, and it helps the patient have an understanding of what we want to, what they're going to experience. And so we also want to make sure that we get that lower extremity when we elevate it to the point of tissue tension, that we get the point of that, or symptom reproduction if we're not getting symptoms. But we should appreciate an end feel at that particular point where it's a challenge to move further beyond that. Again, unless we reproduce symptoms sooner, and that would be important to document where that would be. So how do we interpret the straight leg raise? Well, when we look at the degrees of hip flexion that we get, that's going to help us understand what tissues are likely implicated. So if we can get to the area between 30 and 70 degrees of hip flexion and we reproduce symptoms with that, it's most likely suggestive of a lumbar disc herniation at the L4 through S1 nerve roots. If we can only get to 30 degrees or less of hip flexion, we start to look at some of those diagnoses here. Many of those are red flag findings. And so if we can't get beyond 30 degrees, we have to be concerned about red flag findings or potentially large disc herniations in the form of a protrusion or an extrusion. What if we get beyond 70 degrees? Well, now we're into potential tightness of the hamstrings, gluteus maximus, or the hip capsule, and potentially pathology of the hip or SI joints, because we've taken up all the stress in those tissues and now we're beginning to stress these more proximal structures. And these first three bullets relate to the straight leg raise being performed on the lower extremity with symptoms. And so if I'm dealing with an individual with right lower extremity radiculopathy, right, these first three bullets deal with that. I'm getting symptoms when I raise the leg that the patient has symptoms in. What if we do a cross straight leg raise? So now I have this patient with right-sided radicular symptoms, and I do the straight leg raise on the left side. You would think that it would be normal. But sometimes as we lift the contralateral leg, we do a contralateral straight leg raise, sometimes we actually increase symptoms on that contralateral involved extremity. And so what's that indicative of? It's really nerve root compression, secondary again to a large disc herniation like a protrusion or an extrusion. And protrusions and extrusions these are large herniated discs. They're important because we don't typically see these in normals. We get concerned about a routine herniation because we see that in maybe 75% of an asymptomatic population. Protrusions, maybe only about 25% of asymptomatics. Extrusions, probably less than 5% of asymptomatics. So these are large disc herniations, and when we begin to see symptoms on the opposite side, we do a left-sided straight leg raise and we recreate someone's or make someone's symptoms worse on the right side, and that's their involved side. That's likely related to a large disc herniation and should be considered to be a concern. It's important to be comfortable with the sensitizing maneuvers that can influence nerves of the lower extremity. So for example, if we do our straight leg raise test and we bias that with hip adduction and ankle dorsiflexion, that's going to influence the sciatic nerve. If we take that patient up to end range with their straight leg raise and we bias it now with ankle dorsiflexion and eversion, that's going to bias the tibial nerve. The sural nerve will be biased with ankle dorsiflexion and inversion, and the fibular nerve will be biased with ankle plantar flexion and inversion. And once again, we're looking for reproduction of the patient's primary symptoms. We're looking for asymmetries, one side versus the other, or if these sensitizing maneuvers make the patient's symptoms worse or potentially recreate the patient's primary symptom complaint. In the image there, you can see the examiner using an inclinometer to measure the angle that the hip is flexed to with the knee straight, and that's something we can go back to as we treat our patients. looking at the angle of the straight leg raise could certainly be important, especially if we believe that there is a neurodynamic concern, and we believe that those tissues are not responding to therapy as we think that they should. And so if you're concerned about an issue of neurodynamics, understand the sensitizing maneuvers and assess with those, and then make sure you get a nice measurement on that angle so you can go back to it and recheck and see if that's changing as the patient begins to improve. One of the reasons I think the sensitizing maneuvers are important is because we may go ahead and treat some of these neurodynamic issues that we identify in the examination. And so if we can figure out which nerve is potentially involved, that can sometimes help us with our specific treatments that we'll talk about later when we begin to address some of the neural tension issues. But this is a nice video that shows you the straight leg raise test and then a couple of nerve biases at the end. So take a moment and review the video. Another neurodynamic test that we can use with individuals with lumbar spine disorders is the slump test. And the slump test is nice because this can be employed in a sitting position. And before we begin the test, we'll want to determine what the patient's resting symptoms are, and we'll also want to have a really good handle on what the patient's concordant sign or current symptom profile is. What's their main complaint? Because as we begin to move through each stage of the slump test, we're going to want to determine if we've recreated the patient's primary symptom. If we have, the test is over. It's positive. So in this particular case, we're still going to look at, are we reproducing the patient's concordant sign? Is there a difference, one extremity to the other? And then if we sensitize it, does that seem to, or if we change the sensitization maneuvers, does that seem to alter the symptoms at all? So after we determine what the patient's resting symptoms are, we have a good handle on what their concordant sign is, we're going to have the patient sit comfortably and slump as much as possible, and we're going to want to know if that changes the patient's symptoms. If it does not, we're going to want to employ full spinal flexion with overpressure by asking the patient to look down. Again, if this makes the patient's symptoms worse, we're likely going to probably stop at this point. If it doesn't, we're going to go ahead and have the patient extend their knee. And if that doesn't make the symptoms worse at that particular point, we're going to add ankle dorsiflexion to it. And then at that particular point, the patient is likely going to have some type of symptom reproduction, because we're either dealing with hamstring tension or potential tension through the nervous system. And at that particular point, we would ask the patient to go ahead and lift their head straight up and back up into that extended posture. And once they do that, we ask what that did to their symptoms. If their symptoms got better, worse, or stayed the same. And if the symptoms got better with the inclusion of cervical extension, we call that a positive test. And we'll also look at one side versus the other, do a bilateral comparison again, and we're looking to reproduce the patient's concordant sign with this. So here's the photographs associated with the slump test. We're going to start in the upper left-hand corner, the patient sitting comfortably on the edge of the treatment table, arms behind the back. The therapist is assessing resting symptoms. We have the patient slump, and then we have them and look down toward the floor. And by that, we're asking them to induce cervical flexion, and we'll go ahead and overpress that as well and look to determine if that's changing the patient's symptoms at all. If it does not, we're going to go ahead and employ knee extension with that. We're going to ask the patient to straighten their leg out, and then we can add that dorsiflexion variant at the end there. If at that point we recreated the patient's symptoms, then we're going to go ahead and have the patient lift their head straight up and back. And if that takes the patient's symptoms away or decreases the patient's symptoms, we're going to call that a positive test, because those sensitizing maneuvers are now altering the patient's symptoms. We're actually taking pressure off the nervous system by having the patient extend their cervical spine. Again, looking at bilateral comparison will be important here as well. A slump test will be positive if we reproduce the patient's primary symptom complaint or concordant sign. If a sensitizing maneuver changes the patient's symptoms, such as cervical flexion, and we bring the patient back into cervical extension, or asymmetrical findings, meaning we see less knee extension on one side versus the other. Take a moment to review this video on the slump test. One other lower limb neural tension test that you should be familiar with is the prone knee bend. And the prone knee bend is going to evaluate nerve roots up a little bit higher in the lumbar spine. We've already mentioned that the straight leg raise test evaluates nerve roots likely at L4, L5, and L5S1. The prone knee bend will evaluate nerve roots at L2, 3, and L3, 4. And for this particular test, we're going to have the patient lying prone, and we're going to passively flex the individual's knee. And we're going to look for reproduction of their primary symptoms. So when we're doing this test, we're likely going to have some concern that there's radicular symptoms in these upper nerve roots, and those are likely going to cause symptoms into the anterior aspect of the thigh. When we flex that person's knee, they may feel a quadricep stretch, but that's not their primary symptom complaint. That's the exact same phenomena that we have to kind of figure out when we deal with a straight leg raise test. They're going to experience some hamstring tightness slightly if we go up high enough, but that's not their primary complaint. We're looking to reproduce their primary symptom, the symptom they're coming into clinic with, which in this case could be radiculopathy of some of those upper lumbar nerve roots. And so if we recreate that with the knee flexion, we don't really have to go any further. However, we can sensitize this as well by adding hip extension, and that's going to bias the femoral nerve component. We see that in the bottom image on this particular slide. Again, when we're trying to determine if the test is positive, we're going to use a bilateral comparison, and we're trying to determine if a patient's concordant sign has been reproduced. Is their primary symptom being reproduced with this particular test? And then finally, if we see a sensitizing maneuver increasing symptoms, that's one other component that we're going to add into our intervention, because eventually if there is adverse neural tension, we're going to want to address that at some point, and we'll talk more about that. Take a moment and review this video on the prone knee bend. There's a few special tests that I would like to take a moment and discuss with you. And so the first group of special tests relate to tests to help us determine if patients are likely going to have a need for spinal stabilization exercises. Now, we've already talked about this at some length. We described the Hicks clinical prediction rule as part of our treatment-based classification scheme, that individuals less than 40, folks who have a straight leg raise more than 90 degrees, if they have aberrant motions with range of motion assessment and a positive prone stability test, we mentioned that if 3 of those are present, there's a high likelihood that the patient will have a successful outcome with a spinal stabilization exercise program. There are other important predictors of a successful outcome as well that we mentioned in this slideshow about folks who may have a higher pain score or perhaps higher fear avoidance belief questionnaire scores, if they have frequent episodes of low back pain, if they have hypermobility during our assessment of accessory motion or joint play, our PAVM assessment at the lumbar spine. And so those are other predictors of a successful outcome with individuals who are going to participate in a stabilization program. These 4 tests here, again, the prone stability test we've already discussed, but the posterior pelvic pain provocation test is another test that'll be important. The active straight leg raise test, as well as the Trendelenburg test, which we've described before, that's coming back again. But these are 4 tests again that, if these are present, they provide some evidence again that these are individuals who are likely going to benefit from a spinal stabilization program. We'll also talk about 2 other tests. We'll talk about the quadrant test for the lumbar spine. We spoke about the quadrant test for the cervical spine. We'll speak to that with respect to the lumbar region, and then we need to talk about the sign of the buttock test as well, which is a special test that is sometimes used to assess for sinister pathology in the lumbopelvic region. We've described the prone stability test already, but I think it deserves a quick review. And so the 2 images that we see on the left, the top one is the starting position where the patient lies with their torso on the table, legs off of the edge, and the feet are resting comfortably on the floor. And the examiner will then go through their palpatory exam, performing central PA pressures over the spine. And really they're looking to elicit pain. Once they find that most painful segment with those central PA pressures, they're then going to ask the individual to lift their feet off of the floor. We see that on the bottom image. The individual has just lifted their feet off the floor, just enough to engage the lumbar spine musculature, and you'll notice that they're kind of hanging onto the table there as well in that bottom image. And then the examiner will continue with or perform those central posterior to anterior pressures again over the spine, over that segment that they found to be most provocative or most painful. And then a positive test, a positive prone stability test, would be that there's a significant reduction of the painful symptoms when the feet are up off the floor, when the lumbar musculature are engaged and activated. And this makes sense that this would suggest that a patient's going to benefit from a spinal stabilization program because their palpatory exam is now improved, meaning less painful, less provocative when the lumbar musculature are engaged. We've already shown this video on the first lecture for the lumbar spine series, but if you need to review it, take a moment and watch the video again to see how the prone and stability test is performed. Another test that may be used to determine if a patient is going to benefit from stabilization is the posterior pelvic pain provocation test. And for this particular test, the patient lies supine. The examiner passively flexes the hip up to 90 degrees, and then they apply a posteriorly directed axial force down through the longitudinal axis of the femur. And the test is positive if the patient reports a deep pain in the gluteal region on the side that's being evaluated. And this is a test that is thought to be provocative, potentially for sacroiliac joint dysfunction. And we'll speak about sacroiliac joint dysfunction a little later in the course. But one of the management strategies for individuals who have true sacroiliac joint dysfunction is a spinal stabilization program to help stabilize the SI joint. And this particular test is very helpful in identifying those folks, because if this test is positive again, this is an individual who likely would benefit from a stabilization program. Take a moment and review this video, which will show you how to perform the posterior pelvic pain provocation test. The active straight leg raise test is another test that we can use to determine if patients may benefit from a spinal stabilization program. And to perform this test, we're going to have the patient lying supine with their feet about 8 inches apart, and we're going to ask the patient to lift their legs one after the other about 8 inches off the table. And then we're going to ask the patient if they have any difficulty with that. And we can put that on a 0 to 5 scale. 0 would be no difficulty at all the way up to 5, unable to do. 1 would be minimal difficulty, 2 would be somewhat difficult, etc. And so we're going to ask the patient if they have any difficulty with the test. And if they do, anything greater than a 0, any difficulty at all with lifting that heel up 8 inches off the table, that's indicative of a patient who likely needs a core stabilization program. And there's a couple of different ways that we can potentially address this. We can look at one side versus the other to see if one leg feels heavier than the other. We can also determine if there's pain associated with it, and if there's pain associated with it, I'll show you a video in a second where another aspect of the test is this is maybe thought to be related to maybe some sacroiliac joint dysfunction as well. If you compress the pelvis and just provide some compression through the pelvis, some manual stabilization of the pelvis, if that takes the pain away or decreases the pain to some extent, that again might be indicative of a patient who potentially would benefit from stabilization or even potentially a spinal stabilization belt. One step further with this would even be a patient who we ask to do that transverse abdominis contraction, the abdominal hollowing contraction after they do the test. They tell us there's some difficulty with it. If they contract their transverse abdominis to stabilize just a bit through that core region and have them repeat the test, they may tell you that it feels easier or feels easier or better to do that with that stabilization again. That would be another reason to make sure we're stabilizing these folks with a good core stabilization exercise program. Take a moment to review the active straight leg raise test in this particular video. In this video, he's specifically looking for pain provocation with the exam and determining whether or not stabilization, manual stabilization, or compression at the pelvis assists with that. Again, if you have less pain with stabilization of the pelvis, or it's easier for the patient to do that, that's a good reason to think about prescribing a spinal stabilization program for a patient. The Trendelenburg test will be the last test that we'll speak to, that if it's positive, again, provides some indication that a patient will benefit from a stabilization program. When we spoke about this test in the last block, we mentioned that this is usually indicative of hip abductor weakness. And so again, when we talked about the hip, we spoke about the importance of core stabilization. And so this is kind of coming full circle now that in individuals with lumbar spine pain, if they have a positive Trendelenburg test, we're likely going to have to address the gluteus medius as well as the core musculature in these particular patients. And so in this particular case, we're going to stand behind the patient and we're going to ask the patient to do a variety of different things. We could ask them with some light balance on a table. We could ask them to march in place. We could ask them to stand on one foot. We could ask them to do heel raises on one particular side. What we're looking for is if in the graphic that we have here, on the left, we see a normal hip, meaning that when the patient weight bears on that right leg, the left pelvis should actually elevate just a tad, right? And if we look at the right graphic there, when the patient stands on their right leg, if they have a weak hip abductor, we're going to see that left hip drop or descend on that non-stand side. And so once again, if a patient has a positive Trendelenburg test, this is an individual who's likely going to benefit from a strengthening program or potentially a stabilization program at the core. Another special test that probably should be included up in the range of motion section is the quadrant test. In the quadrant test, we discussed it with respect to the cervical spine, but we'll discuss it here as well. And the quadrant test, in this particular case, we're looking to load the lumbar spine into extension, side bending, and rotation. And we're looking to see if that produces the patient's primary symptom complaint or concordant sign. And so commonly, one of the reasons I'll use a quadrant test is as a screening test, meaning that I may be seeing someone for primary hip pathology, and I go up and I screen the lumbar spine, and as I screen the lumbar spine in the cardinal planes, I don't have a recreation of the patient's symptoms. Lumbar spine range of motion appears to be full and pain-free. If I really want to say that the lumbar spine has been ruled out, I would probably want to use the quadrant test. In this particular case, we're going to load it in all three planes, so we're going to load it back with respect to extension in the sagittal plane, and then we're going to ask the patient to rotate and side bend toward the same side. And so we're loading it in the frontal and transverse planes as well. And at that particular point, if you do that, you can even sometimes overpress this as well. And if a patient does not have reproduction of their symptoms with this, in my mind, you can pretty much rule out the lumbar spine. However, it's sometimes talked about as a provocative test, meaning that we have the patient extend back, rotate and side bend, and we get a recreation of symptoms. If it recreates radicular pain on that side that you're side bending and rotating to, I think it's fair to suggest that we're closing down the neuroforamen on those irritated neural structures. If you're just dealing with a patient who has low back pain and you load them back in this extension, rotated, and side bend posture, you're likely loading the facet joints. And if it's a little bit lower in the SI joint region, maybe around the PSIS, you can also get potentially sacroiliac joint involvement with this test as well. And so it can be used for a variety of different ways. I tend to use it as a screening test, and especially in those individuals who have a lack of provocative findings with my normal lumbar spine range of motion with overpressure. I'll then quadrant test them and rule out the lumbar spine as being a contributing factor. Again, if you use it as a provocative test, it can really mean several different things. And so it can be used in different ways. You should be familiar with it, and we'll show a video on the next slide that shows you as they work through the quadrant test. Take a moment and review this video that shows you the quadrant test for the lumbar spine. Another special test that you should be familiar with is the sign of the buttock. And the sign of the buttock test looks at the amount of hip flexion that can be achieved when the straight leg raise test is performed, and then it's repeated again with the knee flex, taking the hamstrings off of slack. And so the way this test typically goes in the graphic on the right there, the top image, we're performing a straight leg raise, and it looks like we maybe get to about 45 degrees of limitation, perhaps due to pain. If we reassess this individual now with the knee flexed, so now we're looking to determine, can we gain any additional knee flexion with that knee flexed, and we do not. That's a positive sign of the buttock, meaning the amount of hip flexion stays the same regardless of whether we have the knee extended or the knee flexed when we assess hip flexion. And I'm going to show you a video in a second. There's some thought that perhaps this may be related to maybe some bursitis or even potentially a tight hip capsule. But I have to tell you that when you start to see a positive sign of the buttock, it really means something sinister. And so we haven't spoken about that a lot with respect to the lumbar spine because these things are pretty rare, but we're dealing with potential cancers, infections, and fractures. And that graphic in the bottom right-hand corner there, looking at some of the research articles on this, essentially you're dealing with things like fractures and cancers. And so those are reasons that you can't flex the hip beyond a certain point, regardless of whether the knee is flexed or extended. And typically you're dealing with flexion significantly less than 90 degrees in these patients. And so again, this is a red flag finding, and you should be familiar with the test. Palpation of the lumbosacral region will also be key in our examination. When we palpate the lumbosacral region, we'll be assessing tone, ligamentous tenderness, any restrictions in the soft tissue, joint tenderness, as well as bony landmarks. So take a moment and review the video that reviews palpation of the lumbosacral region.